Welcome to Dental XP. My name is Jack T. Krauser. I'm a periodontist in Boca Raton, Florida, and I'd like to share with you some exciting, futuristic information about implant therapy. What we're going to talk about today is an introduction to guided implant surgery. We'll review some of the basics of the Procera software, which is a planning software. We'll look at how we can plan cases in 3 dimensions to get ideal predictability and precision, and a variety of treatment concepts that are available for patient solutions. As an overview, we'll look at the treatment concept itself. We must not forget our basic biological concepts that have gotten us here. These techniques will involve immediate loading, so we'll look at and think about some of the concepts of the different qualities and bone densities that are available in the various patient sites. A very brief review of the software will be included in this presentation, and I would like to suggest that a full training program is recommended, and once you start planning with it, you'll learn how rich it is and how much fun it is to plan cases in this 3-dimensional way. Oftentimes we're asked, does a patient have to get one type of a prosthesis? And the answer to that is absolutely not. We have true prosthetic versatility. We can go from taking the patient's denture that they present with, and just do a reline or modification of that. We could do an acrylic provisional restoration, or we can go to a restoration that's called a Procera implant bridge that incorporates a titanium framework that will allow the clinician to go to a final prosthesis the same day as the surgery. So this is truly exciting, and we'll review some of the basic surgical and prosthetic steps for the case. I always like to start off by reminding us that we have patient bone that we're placing the implants into. The bone densities or qualities can vary. For the purposes of my presentation, I like to review the bone as a hard, medium, or soft quality. This allows me to do my surgical protocol in 3 various ways. If the bone is truly dense, and we can determine this in our planning steps by using the Hounsfield units of density measurement tool in the software itself, we could determine that a hard bone protocol would be utilized. The hard bone protocol would include the use of the bone taps, which come with the precision kit that's available for the system. If the bone is, let's say, medium quality bone, we would just go with the regular drilling and we wouldn't use the bone tapping technique. If the bone is soft, we have developed 2 different types of protocols. We can either undersize the site, and the implant itself will be used as a osteotome or compression method as it's being placed into the osteotomy, or we can actually use some guided osteotomes, which are at prototype level now and should be available in the early part of 2007. When we think about immediate load, we must think about the implant microgeometry or the surface of the implant. This particular product system utilizes the TiUnite surface of the Nobel Biocare implant products. There's ample data and evidence base that when you can achieve a stability of 35 Newton centimeter or more, that implant could be loaded in a very predictable way and go on as an immediate load case in a successful manner. This is in the literature, and we've incorporated these ideas into this Nobel Guide treatment concept. The Nobel Guide concept will use a surgical template or a guide, a pre-made prosthesis, whether it's a provisional or a final restoration. There's the computer planning, and then the concept of the teeth in an hour, which incorporates the final prosthesis at the same time as the surgical delivery. This would be an example of a scanning electron micrograph at high power showing the unique surface of the TiUnite with tissues that grow into the micro and macro pores. These truly are allowing the clinicians to have a very stable bone implant contact. This chart comes from the work of Glauser and Schupak from the group in Switzerland. The red line is the TiUnite surface, which indicates that early on there's a drop-off in the initial stability. However, it rebounds rapidly and goes up to the original stability state at an early time point. The yellow would be an earlier surfaced implant like the titanium surface, where there is a significant drop-off, a plateau, and then it rebounds after about 3 months. By using these enhanced surfaces, the implant is actually at risk for a shorter period of time, and we've maintained the stability for a longer period of time, and it's pretty clear on this chart. So we like to consider the Ti-Unite for our use in these cases. Another subtle yet powerful change in this implant design is the use of the threads in the macro geometry aspect of the case. There are threads that are in the flank of the thread itself, or like little micro grooves in with the thread of the screw itself. With various studies, blood will absorb to these surfaces very nicely, and we know blood is the first tissue that will touch the implant surface when it's placed into the site. The work of Shupak has shown us that in these little sub-grooves there is actually tissue ingrowth that's very stable. The histological view on the bottom shows bone in the brownish color growing into these little threads. It can be quantitated that there's actually 25 to 30% more bone implant contact with these little sub-threads on these implant surfaces. So if we're going to do an immediate load concept and we're able to have a surface, the Ti-Unite, which will rebound more rapidly, put the implant at risk for a shorter period of time, and get 20 to 30% more bone implant contact, we're truly utilizing a correct system for the foundation of our prosthesis using this methodology. Further, you might have noticed in the previous implant that there is a Ti-Unite surface all the way up to the top of the implant. This has been challenged and is somewhat controversial by some previous clinicians who have suggested a polished titanium right up to the top. We know that polished titanium will only form a soft tissue cuff without any actual attachment of the soft tissues to the surface of the implant. Now, if we look at these slides, we're seeing the soft tissue integration that is possible with the Ti-Unite surface, where the connective tissues are actually incorporating in a functionally oriented way into the surface of the Ti-Unite. So again, we have a design feature of the grooves, which get greater bone implant contact, and the design change, the Ti-Unite up to the top, which allows for a predictable incorporation of a functionally oriented connective tissue zone. So by protecting the underlying bone with these connective tissues attached truly to the implant, we've developed a very safe system to work with. The first step after the prosthetic planning would be a correct scan. A medical scan or a cone beam scan can be utilized. In my practice, we have what's called an Imaging Sciences iCat, which is a sit-down cone beam device which will give us a very useful CT for the patient in 20 seconds or less scanning time. The radiation is approximately 100 times less than a medical-grade CT, but the beauty of this is it's a versatile tool in our practice, allowing us to get the information right on the spot, and we don't have to take a patient to a scanning center or deal with any perhaps complications that may take place. The footprint of this device is the same size as a panoramic, and again you can see a patient in a sit-down way, which allows for the patient to be treated in a very comfortable manner. This system also requires what's called a double scan. The second scan is actually the radiographic denture, which will be scanned by itself. The patient will take the radiographic denture with some gutta-percha markers for the first scan. It is critical to use gutta-percha at this point because the density of the gutta-percha is programmed into the software, and the programming itself will be looking for the markers. So the patient wearing the denture will be compared to the denture alone, and the markers will be utilized to line everything up. If you notice, there's a question, is there a final prosthesis? Unique to this ProSera software is the ability to create a final prosthesis. The other softwares that are available can get to a scanning template or a treatment template, but not to a final prosthetic design. So what is the Nobel Guide? The Nobel Guide is a custom, patient-specific, precise guide or template that will be based on our computer planning. From a surgical perspective, you do it in a above-the-tissue design, so you're getting a flapless approach or a minimally invasive surgery. Teeth in an hour is a part of the Nobel Guide concept. It takes it to the next step where the prosthesis is created at the time prior to the surgical events, and a partner laboratory that will work with the milling titanium will get a framework that's precise to fit on top of the pre-planned implants. This alone is a huge reduction in the prosthetic phase of the case. If you're doing the restorative aspects of the case, think about how many steps and how much chair time is involved in the impressions, framework try-ins, the various bites, the adjustments, and if things don't go right, how many steps you have to go back and forth. So this is a very, very useful tool for the surgical member as well as the prosthetic aspect of the case. On the bottom we see a graphic of what a Nobel guide would look like. It's a surgical template with horizontal anchors and little guide sleeves which will three-dimensionally position the implants in the ideal spot. This is what goes to our laboratory partner. This is the actual guide that comes back to our office. This is the inner or the intaglio surface of the design, and it is fitted with custom parts that fit the sleeves and are made specifically for the Nobel Guide concept. From this, the laboratory partner will be able to create a soft tissue model using the flowable material. A stone replication is placed. There are analogs of all the different steps that are added at the laboratory phase. And a master model is then created. The master model is actually a replication of where the implants will be positioned in the patient. So by having this before our surgery, we can then create a prosthesis to bring to the surgical day, and the patient can either have a final prosthesis or a provisional restoration based on this surgical model workup. The Teeth in an Hour utilizes the three-dimensional planning. We then send the final plan through the internet to a scanning and CAD-CAM site that takes our data into their computers, and CAD-CAM protocols are done which make a resin-based guide, and the guide sleeves are positioned which are in 3 diameters, a 4.3, 5, or 6. These will correspond to the final diameters of the various implants in the Nobel system. We also know that there's a 3.5 implant in the Nobel system, so for that we would utilize an insert into the 4.3, which will give us a three-dimensional positioning of that particular implant size. Again, the intaglio surface that's being worked on at the laboratory phase. This would be a master model and a final prosthesis in the lower jaw case. This is an upper jaw case showing the insertion of what's called a guided abutment. We'll look at that in greater detail in a moment, but the guided abutments are non-engaging, clamping type of abutments which will fit on top of the implant, and then with a conical thread will fan out like a molly bolt and lock to the inside of the prosthesis, clamping it to the top of the implant. You can see on the left the clamping aspect on the bottom. There's a slot on the top and the conical screw. So as you're turning the conical screw into the abutment, it gets locked into the titanium sleeve within the prosthesis, clamping it into the prosthesis to the top of the implant. This allows for very, very minute discrepancies which could occur. We've found that the discrepancies are in the 0.1 millimeter order, and I have not personally had any cases that have not seeded for our patients. While we utilize the concept of teeth in an hour, we shouldn't forget that there's a lot of preclinical aspects that are traditional that must go into the planning and the pre-prosthetic phase of the case. For example, in this view, a patient is having a denture conversion. The contours must be made ideal by our restorative teammate. The fit must be ideal. And if it's a denture that's useful, but a soft line is what's being used in that case, you must convert it to a clear acrylic duplicate denture or make a duplicate denture. When we're doing the radiographic scanning, we do not want any soft line material in the prosthesis or the radiographic scan. So this patient had contours. They approved the length of the teeth. They approved the lip support. The occlusion is adjusted at this point, and all of these aspects of the case are going to be transferred through the DICOM files or through the internet and will become part and parcel of the information that the computers will use to develop the final case. Preclinical views show a double edentulous jaw. We're going to do this patient, the maxillary jaw, with the guided approach, and you can see this is a very robust bridge, thick tissues, excellent keratinized tissues. Now, oftentimes we're asked, what do we do if we have thin keratinized tissue? I suggest two things. If we're going to do a pre-surgical phase, you must wait for at least 2 or 3 months prior to doing any of your scanning. On the other hand, you could precisely place the implants and on the same day do a surgical phase at that time, because you don't have to worry about the guide not seating on the surgical tissues if you do it afterwards. So there are ways of manipulating the soft tissues if necessary for the soft tissue augmentation phase. As I mentioned earlier, this patient had a soft line, so a clear duplicate denture was created either by a laboratory technician or we can do it in our office with the duplicator flasks. You'll also notice little pink gutta-percha markers which are placed on the outer surface and the palatal aspect of a prosthesis. If it's a partial case, you want to ensure that there are significant flange heights and depth onto the tuberosity regions or retromolar regions to allow for stability of these prostheses. In a full denture case, you can place the gutta-percha points. The computer will look for a matching set of 4. However, we recommend putting in between 10 and 12. That would allow for no problem in getting the 4 minimum as a match. The gutta-percha points are approximately a number 6 or number 8 round burr in circumference and in depth. And the palatal aspect of the duplicated denture. So in the mouth, the patient is wearing it. You can see the gutta-percha in higher power. This slide will demonstrate the different aspects of what's necessary when the patient goes to the radiographic scanning center or if you're doing it in your own practice. This will also show why it may be important if you feel like doing a lot of these cases, you may want to have the cone beam technology in your practice. Scan 1 will be the patient, the marked radiographic denture or duplicate denture with the gutta-percha markers, and a polyvinyl siloxane or similar bite. The bite is to distribute the forces in a uniform way against the jaw that's going to be scanned, and it must occlude in a firm way with the opposing arch. This is a step that oftentimes the radiographic colleagues at scan centers may overlook. Sometimes a patient may forget to bring their appliance with them, so it can abort the entire scanning technology. So the first scan is done, patient, radiographic denture, and a bite. The second scan is the radiographic denture alone at the same plane that the patient was sitting. If we have a sit-down device like an iCat, then you take the denture on a platform and scan it, and it'll be at the same plane. On the other hand, if it's a medical grade CT, the patient will oftentimes be in a lying down position, and they have to secure the denture in a lying down way, up and down, to allow for the denture to be scanned in the same plane that the patient was scanned. Now the information is sent over to us for our planning software steps. This can be transmitted through the internet, through a jump drive, through a key, or through CD disks. For example, if we get it on a disk, we would load it into the software and we would open up the D drive, enter it in to the software, convert that data, and place it into the software planning itself. These images are of step 3. Step 3 is the fun aspect of the case, where we actually plan the cases in 3 dimensions. If you look at the left side, or the blue screen, that's a virtual, interactive, 3-dimensional side of the planning software. We can rotate it around totally. We can put the denture on, put the denture off. We could put the guide sleeves on, off. We could remove the bone. We could remove the prosthesis and just have the implants in space, which will show us virtually where they are. And there's a halo or a 1.5 millimeter safety zone around the implants that would allow us not to put the implants too close together. So the screen on the left is virtual and it's 3-dimensional, and you could rotate it and manipulate it. The screen on the right that shows the radiograph and an implant that's been positioned is a 2-dimensional view, and we oftentimes will place the implants on the 2-dimensional screen. You'll see on the bottom there's a prosthesis. You can see a variety of depth of the soft tissue or the palate. You can see the sinus area, and you can see the buccal contour. So an appropriate length implant is positioned on a 2-dimensional screen. In the middle, there is a toolbar that goes up and down, which will allow for the track, if you will, to position the implant sites at different areas of the teeth. And that just rotates right around the arch allowing us to position the implants in an ideal way. Through the use of the icons and the various tools, we can check bone density with the Hounsfield units, we can check angulations. There's a little camera in the middle. We can actually get a visual image and save it for the planning or a lecturing purpose if you wish. You can see the various tissue thicknesses, so you know how deep to place the implant. And by rotating the side on the left in a three-dimensional way, you can see how deep the implant will go. You'll know if you're going to have to use a tissue punch or the implant will be at the level of the bone crest. This would be a planned site, almost done. At this point, we would save the plan and move to the next step, step number 4. And just looking at it again at another view. There are several steps that take place up to step 7. Step 7 is called Order Manager. Order Manager is another module within the ProSera software system that allows you to uniquely use your 3-digit code to send through the internet the data that you just created for that particular patient. So nothing is sent that's hard. It's all done through the internet. It's received by the CAD/CAM facility. It's downloaded into their computers, uploaded, and a rendition of the patient's jaw is created, and a resin guide specific to that patient is created, which you see in the lower left. You'll also see these anchor pins that are the horizontal pins and the guides, which are in 3 diameters, as I mentioned earlier.